Today we have Dr. Jennifer Wells and Michelle Diehl here to talk to us about VMAP for Moms Plus.
Hello.
Dr. Jennifer Wells is Director of the Women's Mental Health Division of the Department of Psychiatry and Behavioral Medicine for Carilion. She's board certified in Psychiatry and Addiction Medicine, serves an assistant professor for the Virginia Tech Carilion School of Medicine. She's also the Psychiatrist lead for VMAP for Moms Plus, a statewide initiative that provides education, clinical consultation, and care navigation to medical providers of pregnant and postpartum people. Michelle Diehl is the VMAP for Moms Plus licensed mental health professional lead. She's been with Carilion for 9 years. Michelle completed her counseling residency with Carilion Clinic to obtain her LPC. She has worked in addiction services with a special focus on pregnant and parenting patients, as well as at Hollins University student counseling contracted through Carilion. Please join me in welcoming Dr. Wells and Michelle Diehl.
It's not needed. Can you all hear me? It's not a big room, so I don't know. If I stand behind here, you can't see me, and I cannot see you. Just welcome to being short. I don't understand how you guys get up at 7:30 for a great round. So, kudos to you for making it here. Our job this morning, I was here, I think maybe 15 months ago, and I did a pediatric round around perinatal mental health. And that was more focused on the actual diseases and diagnoses we use and how we treat it, and maybe where pediatricians can step in and help us. And this one is focused on part of the way that we as the state of Virginia, and also we as Carilion, have tried to address this problem, is to build on the VMAP line, which I would assume or hope probably everyone in this room is familiar with. Yeah? So VMAP, Virginia Mental Health Access, originally started in 2019, federal and state funded program designed originally to help pediatric providers find resources, education, clinical consultation, and care navigation for their pediatric patients with mental health issues. VMAP for Moms Plus is the perinatal extension of VMAP. And it's our goal to help prescribers of pregnant and parenting people to better care for pregnant and parenting people who are suffering from perinatal mood and anxiety disorders or perinatal mental health problems. We call it PMADS a lot, but I think it's sort of switching to perinatal mental health, and PMHD doesn't have, it doesn't sound as good as PMADS. So that's why I'm here this morning, and part of what the first thing, that didn't do it this one. Okay, that one. Thank you, already getting up to So part of what we're here to do today is just let you know about VMAP for Moms Plus if you weren't already aware. This program actually started as a hub, our first hub. VMAP has several hubs throughout the state of Virginia. VMAP for Moms Plus is just starting out. We have a single hub. It is started here at Carilion Clinic. I am the physician lead for all of VMAP for Moms Plus, and I'm also the person, if you call the line on Monday or Friday afternoon, you get me. If you want a clinical consultation. And so we're excited that it's actually housed in Carilion. We have a partnership with Postpartum Support Virginia. So they actually work in concert with us to help provide some of the resources that we want our patients to have going forward. And so we're here to introduce it to you this morning. If you weren't aware, to learn what our main services are, it's much like the regular VMAP. We're just an expansion sort of in the same footprint. And to identify how it might be useful for you. I think pediatricians, you didn't set out to treat pregnant people, or goodness knows moms. But I think probably increasingly you have an understanding that if we don't help the mother, then the child is affected. And so we're keep moving the ball upstream. The more we help the mother, the better off the child is going to be, and that is inclusive of her pregnancy. The more we have a healthy pregnancy, the more we have a healthy fetal environment, the more we have a healthy newborn, the more likely we have a healthy and emotionally fit child. So that's where you come in. And in the postpartum period, sometimes you're the first person who encounters mother who is suffering from a perinatal mood or anxiety disorder. She might not tell, they might not tell anyone else, but you might have had the relationship from an earlier child. So you might know this parent quite well, and you can see something has changed. And so this line can serve as help for you, and it isn't hard for you as a provider who may not be caring for the mother to actually get her to care. And so we're here to sort of help you understand how you could do that, maybe with sort of minimally affecting your day because you're busy and you don't have a lot of time to care for extra people. I know I don't. The scope of the problem, in case you weren't aware, but you probably are, perinatal mood and anxiety disorders affect about 1 in 5 patients in pregnancy or postpartum. About 75% never receive treatment. 75, that's a big number. We think we do a little better with depression, maybe somewhere around 65% never receive treatment. So we're back up around 40%. That's better than 25. But a lot of things are still falling through the cracks. There's still a lot of stigma. We have a belief in our society that, having a baby is a simply wonderful thing. Increasingly, I think we can acknowledge that given all the factors that we're facing these days, it's harder to make ends meet. It's harder to live in this world effectively and feel like you're equal and you're supported. And so we're seeing, I think, mental health be affected as a result of that. Perinatal mental health issues are the leading cause of maternal mortality in America. That's a bad thing, right? What are the number 2? Suicide and overdose. Both of those things we have the ability to affect, right? They fall under the mental health rubric, and all of us can help with that, even if it was just a Narcan prescription. Left untreated, we know that health conditions, including mental health conditions for the birthing person, affects the child, the developing fetus, infant, babies, toddlers, mothers other children in the household, other parents in the household, even grandparents. Mental health is transgenerational, particularly when we're talking about substance use. Often you will see it as not a learned behavior, but it is normalized as something in a household. And so if we have generational families living together, that substance use gets sort of passed along as something that's okay. In Virginia, 100% of Virginia are mental health professional shortage areas. Well, that's great for my job security. It's not so great for the wait times to get into an appointment to see me. And I am probably one of maybe 20 or 25 in the state of Virginia, probably less than 1,000 in the United States of America, who focus on perinatal psychiatry. And so what we need is help. And we can get it from anyone who is interested in mental health, and we all sort of need to be. So I'm sort of, my job as part of VMAP for Moms Plus is pushing prescribers to work to the top of their license so that when you see a problem, you can identify it, get help for it, and our patients get better care. Virginia ranks 39 lowest in the country for the number of mental health specialists available. Not surprisingly, you just heard the numbers I gave you. And there are low numbers of all of us working in maternal health care. We are an obstetric desert in many parts of the state of Virginia. Labor and delivery units are closing throughout our state. It's really dramatic. So even care around, you would think obstetrics and gynecology are maybe the largest providers of perinatal mental health outside of someone like me, and they would be, except we don't have enough of them either. So the numbers dwindle for each of us. I don't know, do you guys know how pediatricians fare in the state of Virginia? Are there enough of you? Anybody know? I don't know either. Perinatal mood and anxiety disorders, #1 complication of pregnancy and childbirth. They can occur from conception. We call to the baby's first birthday. Increasingly, we space that out. We say baby's first birthday to age 3. I would bet it's probably closer to age 5. As we learn and gather more data that the recovery from a pregnancy that incurs a perinatal mood and anxiety disorder is much longer than someone who is healthy and is physically recovering and emotionally recovering from just the birth of a child. When you add on depression, anxiety, OCD, even a psychosis, the time to full recovery is years long. Women with a history of depression, anxiety, mood disorders are 30 to 35% more likely to develop a postpartum depression. So maybe that's where you come in. You're seeing the parent whose first child had a fine delivery, but mom had a little bit of depression. You happen to know that. She gets pregnant again. She's bringing in her little one. You see her and you can feel her mood dropping. Death by suicide and accidental overdose are the two leading causes of death for postpartum persons in the U.S. within the first year after birth. That's a pretty striking statistic. 1 in 5 people generally affected by PMAD. 20% of pregnant and postpartum patients are screened for depression, which is actually an improvement. They'll say 50% of women go undiagnosed for depression. So we do a little better with depression than we do with other perinatal mood and anxiety disorders. If you think we have around 95,000 live births in the state of Virginia, that's close to 20,000 Virginians that will experience a PMAD this year. Up to 40% of Black mothers will experience a PMAD. That's nearly twice the baseline rate of all women. So looking around at our persons who suffer social or sexual inequity is going to be something where their rates of a perinatal mood and anxiety disorder go up. And we know that rates of depression in Hispanic mothers is about 40% higher. So stepping outside of your average person rates out in anyone who is different race is going to increase. That sounded awkward, sorry. Death by suicide, I mean, I've said it any number of times and we keep saying it, the risk of death by suicide is highest between 6 and 12 months postpartum. It's one of the leading causes of death in the first year after delivering a child. I think it's interesting that it isn't immediate, right? So that's 6 to 12 months. So who's seeing a postpartum person 6 to 12 months postpartum? You guys, right? Because it's the infant that's coming in. She's passed her postpartum check, that's 6 weeks. If she's not engaged with a psychiatrist for maybe a previous mental health disorder, doesn't even know she's suffering, she's not seeing a psychiatrist. But you can be darn sure that every mom is trying to be the best mom that they can be and is trying to bring her child to her pediatric visits. And so you might see it there. Perinatal individuals with PMADs have 3 times higher risk for suicidal behaviors than those without. So that risk is really important to know. That risk is more than double 5+ years after the birth of their child. So it remains static. So people who have suffered from a perinatal mood and anxiety disorder are at risk for a long time after the birth. And we know that suicide attempts by perinatal individuals typically involve more lethal means. On a community level, it's costly. $32,000 is the cost of an untreated PMADs in a mother-infant dyad. They come in for more care, right? Often people who have mental health disorders seek treatment for physical health disorders because they mislabel their signs and symptoms, and they also don't want to be depressed or anxious. We naturally in our society lean towards a more physical cause. Affected individuals often leave or delay reentry into the workforce. A mom that's recovering from her postpartum period who's suffering from terrible anxiety is more afraid to go back to work. It's more hesitant about taking on more responsibility, which leaves more time out of the workforce. And we know that they have negative health outcomes for babies, toddlers, including developmental delays in homes where we have depressed parents. So you can see it's important and we need you. So what are we going to do? Michelle's going to tell us. She's got all the answers. Oh, let me take a look. Thanks, Lovey.
Good morning, everyone. All right, so what is the solution to the problem? This is a solution. It's not always going to be the solution, right? But we're trying to come up with something for the toolbox, something to move toward progress in it. Let's get into it. We already went over the history of VMAP. That's just a little rundown of kind of how we evolved over the years. And this was just to highlight what Dr. Wells already mentioned, that our hub is housed here in Carilion and kind of partners with Postpartum Supports Virginia, but we're really the central hub of it, serving the entire state. Perinatal psychiatry access programs are increasingly coming about, I suppose. This map's actually out of date now. They're releasing a new one very soon with more states adding to this. And it's actually become a network to try to continue to evolve and improve state by state. So we all get together at least quarterly and kind of talk about what we've seen, what can be improved upon, and how to make things more seamless and smooth, because we recognize the barriers in it in the sense that time is limited. You guys are busy day in and day out. So making a phone call may not seem like a big deal to some, but we know how precious time is in your day. And so we are constantly assessing that and trying to make it an easier avenue to take for everyone. So similar to the pediatric line, if you're familiar with that, we're a two-pronged approach. We have our provider education, which comes in the form right now of our PEACE training. It's a 2-day training. We'll talk about that a little later on, but we are expanding that, and even that, knowing that sometimes 2 days is hard to take it off, right? It's hard to make that commitment. So we are trying to come up with more flexible opportunities to increase our education. And then on the other side, which is kind of our ongoing everyday bread and butter, is our consultation line. And so it's a free mental health consultation line and care navigation for any Virginia prescriber who provides care to pregnant or postpartum individuals and or their children. And so with that, you get access to perinatal psychiatrists. We have a team of 8 to staff our line Monday through Friday, 9 to 5. Dr. Wells is one of those wonderful perinatal psychiatrists. Actually, several of them come from Carilion, so even on that side of things, it bolsters up that we're kind of spearheading this hub. Licensed mental health professional right now, that is me. I am the only one in the state right now, but we're working on expanding that.
We're trying.
Because I am one person. My brain doesn't always know that, but we are working on getting extra help. And I'm the one that's 90% of the time answering the line. We want to get that clinical lens started right from the gate. Any information that's coming through, I'm filtering through that clinical lens. That way, if we do need to go into consult with a psychiatrist, you guys aren't having to repeat yourself, save a little time, and you can already be conceptualizing with the psychiatrist kind of mid-second one when you get on the phone with them. And then our care navigators, which we'll talk more about because they're a little unique to the care navigating space. So what is the goal of how we work? Theoretically, we'd love everybody to take our PEACE training and kind of get that education up front so that there's a different lens you're looking through when you're meeting with these patients. It doesn't always have to work that way though. Sometimes you just hear about us, you have a patient come in that day and it kind of triggers in your brain, oh, call VMAP for this. So a provider calls our line. 9 times out of 10, you're going to get me and I'll take an intake. And what that looks like is pretty basically the information that would be on their face sheet. So we need insurance information so that we're connecting to the right services. If you're using care navigation, we need zip codes so we can be looking for services in their local area. We need a good contact phone number. I'm trying to think of things that we do ask about the pregnancy a bit, but when I have a pediatrician call me, I have kind of a different intake that I would use in terms of, you guys might not have mom's date of birth. You might not have some of the information that we would gather from a direct prescriber to the mom. So if you call us and you're worried about not having the information because mom's not your direct patient, that's not a concern, that's not a barrier. I have ways to work with that. We've come up with codes to be able to put in if that information is not available. So we complete the intake, and typically for pediatricians, we go kind of straight to care navigation because there's only so much you can provide for mom. And what that looks like is getting mom connected directly with services that may be helpful to her that she's agreeable to. We do let the patient kind of guide it to some extent. And the unique part about our care navigation team is we have this perinatal database throughout the state that's been vetted. Nobody on that database is on there without us talking to them first and understanding them kind of in a holistic way. So we vetted every service on there. We don't make referrals to these services. We help the patient, empower the patient to connect with them themselves. That may mean doing like a three-way call with them and the service. But our goal is to empower them to make the connection. So there's more of a warm handoff that's happening, but it's not a referral process. We have found success in this just with that follow-up and getting them into services quicker versus just providing the services and leaving it in the patient's hands. That warm handoff seems to have kind of a closed loop time frame in terms of we don't see them dropping off, coming back to us, dropping off, coming back to us to get into services. Once we provide the services to them, we help them make the connection. They tend to get an appointment within typical time range is 2 weeks. That's depending on wait lists at some places. We can't really work around the wait lists, but we can keep engaging the patient and help them figuring out what's stopping them from making the appointment. So there really is a relationship that's built there to help empower the patient. And that alone kind of provides some support that they may have been missing before. Sometimes pediatricians do consults with us, and it's in a different way because, again, you're not the direct provider for mom. But what we've had is pediatricians call, mom feels very comfortable with them because, as Dr. Wells said, a lot of times what we're seeing is either this pediatrician has known this mom since they were young and they were treating them as a pediatric patient, and now they have their own children, or they've had other children that the pediatrician has cared for. So there's this strong rapport that's already built. And mom will share things like, maybe their provider encouraged them to stop medication when they found out they were pregnant. Well, and a pediatrician feels concerned for mom for that. They may call and do a consult with us just to be able to tell the patient how to help them talk to their own doctor. Here, take this information back to your doctor and you guys can have this conversation about it. So we use consults in a different way for pediatricians because we recognize that you're limited in how much you can actually provide for mom, not being the treating physician for mom, but for the infant. This is just kind of my catch-all slide where all of our information is. Our goal is same-day consultation. So our goal when you call us, if you ask for a consult, is to get back with you within 30 minutes, unless that's not good timing for you. We also try to accommodate what your day looks like. So maybe your lunch break's at 12 o'clock and you feel comfortable calling us then when you have a little more flexibility. Maybe it's towards the end of the day when you know your clinic time is winding down and you might have a little more flexibility. And then I reviewed most of the rest of this. I won't go over it again. I don't know that this would happen in this area, but the kind of barriers we work around is either the treating provider, or in your case, the pediatrician must be in Virginia or the patient must be in Virginia. So the example I tend to use for this is Bristol. So if you have a pediatrician that's in Bristol, Virginia, but their patients live in Bristol, Tennessee, we can still provide services for that, as well as vice versa. Right now, we're working in this constraint of patients must be either pregnant or up to a year postpartum. I'm not going to turn anyone away. So if you have a mom who's got a 2-year-old and you recognize that mom may still be dealing with some perinatal mental health concerns that went unaddressed earlier on, still feel free to call us. Outside of like 3, I start having to question, is this for us or not? I'm really bad at turning people away because I just want to help. I had a pediatrician call with a mom of a 15-year-old one time. And I took it and I shouldn't have because it really should have been the pediatric side. But I didn't want this mom or pediatrician to feel like they didn't have anywhere to turn. Worst case scenario, just call us and we'll get you to the right place. I'm not turning anyone away.
That is part of it too, because we are connected, right? Like we're connected to VMAP as a whole. If you end up in the wrong place, we'll get you to the right place, right? There have been people with addiction, and some of us are more skilled addiction providers. We'll get you to that person so that we direct your care. We have a lot of room and we collaborate with the VMAP mainline, and then we have also connected to VMAP is APAL, or Adult Psychiatric Access Line, which is right now focusing on substance use. So if you had a mom who was outside maybe the initial window, but you called us, if we thought it should go to APAL, we're going to refer you out to APAL. But if it were my day in the afternoon, I might just handle it because I do addiction work a lot. So we'll try to work with whatever you need. That's part of the nice thing about kind of right now, we're small, our hub is here. Michelle and I are talking all the time. Every one of us knows where to find the other so that we can sort of tailor services. I think as we get bigger, that gets harder, but part of what makes us unique is how we built ourselves to sort of customize our delivery. And I think a part of us will always want to do that.
Yeah, well said. The QR code up there is for registering as a provider with us. It's not a requirement. When you call us, I can get you registered. When you call, it does save a couple of minutes on that initial phone call. If you are already registered because you have used the pediatric line, you do not need to register for us again. It transfers over. We keep one VMAP provider database. So not necessary, saves a little time if you're not already registered, and you keep updated with new developments. So we will have new education developments this year. You would get updates about that. So it does have its perks, but again, not required. Some concerns that we can help with, and this is by no means an exhaustive list, but it's kind of the main things that people call for, just case conceptualization. There's a lot of things going on with a mom or a family, and you just don't really know where to start with it. Screening, this is one we get a lot. You guys use EPDS or any kind of screening? Cool, yeah. So that's one I get a lot from pediatricians, is that, they did an EPDS, mom scored fairly highly, or there was some positive screening on question 10 regarding self-harming thoughts. So we can help direct that. We can help talk through it with you and kind of find a good direction to go towards. Diagnosis is an area we can help with. That can get tricky because symptoms can kind of overlap in different places. So it's one that I think dumps providers or makes them feel a little less comfortable is it anxiety, or are we looking at perinatal OCD? Is there a potential bipolar disorder on board? Things like that. So we can help kind of give some clarity to that. Prescribing, that one wouldn't really apply to you guys for this line, but would for our peds line. Again, I have had pediatricians want to be able to help mom verbalize to her own provider how to talk about this, and they have called to get some guidance on how to empower mom to do that. Any kind of medical care considerations or implications that may be going on. Level of care determination. This is one that I try to focus in on a lot because when we're connecting patients to services, I don't want to connect them to a service. They go to do their intake and that service says, oh no, you need more than what we have to offer here. That is a really defeating feeling. So we really utilize level of care determination, very similar to ASAM's levels of care. Care navigation for the perinatal individual. Typically how it goes is after I get a concept of what's happening with mom, then I'm able to direct care navigation from a clinical lens. So if we know mom has a history of trauma, I'm not just gonna direct care navigation to look for perinatal counseling. I'm also gonna ask them to look for perinatal counseling that has been trained in trauma treatment modalities. So we really try to cater and specialize to the individual parent. All right, so I know I've showed you this one before and I threw myself off for a minute because I was like, why did I do that? This is actually a case study. So this was I wish I had adapted this, and I will do that going forward with a pediatric case, but this is kind of one of our gold star cases. This is really what we aim and target for every time we get a call. It does not turn out that way every time. I wish it did, but to me, it really highlights what our mission is and how we work as an interdisciplinary team to achieve that. So OBGYN gave us a call. She actually called us at the urgence of her patient. Her patient had gotten in contact with Postpartum Supports Virginia because she had been struggling with some perinatal mental health concerns. Postpartum Support Virginia gave her our information and encouraged her to give it to her provider. So the OBGYN calls and says, I'll be honest, I don't know anything about you, but my patient told me to call you. I was like, okay, well, cool. Do you have a minute for me to tell you what we do so that we can be on the same page? So I was able to give a little education there. So education is a big part of our mission and goal. Part of what we're trying to do in expanding access isn't just connecting to the services already in place. It's trying to expand access in the realms that these perinatal individuals are already encountering. So I was able to provide a little education to this OBGYN. She gives me a synopsis of what this individual's been dealing with. So she had presented to the ER several times over the previous month. She was about 5 to 6 weeks postpartum. I put it in there, 6 weeks postpartum. So that she had 2 weeks after baby was born where things were okay, kind of baseline for having a 2-week newborn, right? And then it was at week 3 that things started to get hard for her. So she had presented to the ER several times over that month due to inability to sleep. She was getting no consistent sleep through the night. It was very unorganized. She had slept, per her report, 10 hours during that month, the month that she was going to the ER. The ER had prescribed Zoloft, hydroxyzine, and Ambien. She self-discontinued the Ambien because she saw no benefit from it. She has a great support system. Her partner and sister had gone to her with all of these ER visits, all of these pediatric appointments, OBGYN appointments. They were there to support her. So she had a fantastic support system. No prior mental health history, and an EPDS score of 18. So I was the one that took the call. I educated provider on what we did and how we could help. I gathered the mental health symptom presentation to guide care navigation and to start conceptualizing for the psychiatry consult. I engaged one of our perinatal psychiatry consultants. Dr. Michael Anderson was on that day and helped me out. He consulted around medication management and recommended a trial of medication to aid with sleep and appetite. I believe he recommended Reproductive and to increase the current SSRI, which was Zoloft. Once that was, they had kept the patient in the office during this time too. So mom had not left yet. OBGYN was able to relay these medication recommendations with mom and get those sent into the pharmacy before mom even left the office. Once psychiatry consult was completed, I engaged care navigation. They connected with mom the very next day because it had gotten pretty late in the day at that time. Connected mom with perinatal psychiatry that also offered perinatal counseling within that same practice. That is not always possible depending on what part of the state we're working with, but it was with this one. There were some language barriers. English was a second language for mom, so up to this point, that's how she had been operating, but going into more in-depth things like counseling and psychiatry, she really wanted to be able to reduce any potential language barriers. So we engaged insurance to aid in the translation services. Translation services are not available at every practice. We have gotten pretty skilled at working with the insurances, which is not an easy feat. And that's what we did here. We worked with the insurance and the practice to time things up for that appointment. She had her intake 2 days after we engaged. Her first appointment was within a week. Mom's next step before they contacted us was seeking inpatient care. She was getting to a point where she was very concerned about how she was going to be able to continue. Because we were engaged and because this medication got started and we got her connected, that first night when mom picked up the medication from the pharmacy, she slept 14 hours. 14 hours compared to 10 the previous month per her report. So it really was a full circle in terms of how we tend to operate. Now again, this is our gold star case. This case just brings me joy every time I talk about it because it really is what we're aiming for. We do aim for it every single time. It's just with constraints of resources, so many factors. Insurance type, all of these things play a role, but this is what we aim for, and we get as close as we can. What I will say is, in terms of connection to services, we don't have any special ins or outs, right? Like I don't have any special cards to pull. I can't skip wait lists. I can't call Dr. Wells and say, please take this person and get them in tomorrow. We don't have that kind of thing, but what we do have is community relationships. Everyone that we refer to, we have built relationships with. So a lot of what what we're doing is that warm handoff in terms of how do most people schedule appointments these days? On the computer, right? We're calling directly to these services and asking what their availability is, asking what insurances they take, asking for any updates on their practice. And so they're able to pull up their schedule right there and put the patient in wherever there's an availability. And so you miss that kind of human connection. And that's kind of our whole goal with VMAP, is to be a partner. We don't want to just be a resource. We don't want to just be a referral source. We want to be a partner with the provider that's calling in to us. So we want to be an extension of the treatment team. Same for the patient. We want to be an extension of their support system. Peace training. So this is a 2-day CME training tailored for Virginia prescribers. It's 15.25 CMEs. I think it's $100 still.
It is still $100.
And that includes lodging.
Can't really get better than that.
Lodging and breakfast and lunch.
Correct.
Yeah, really great deal. Really great deal. What you'll look at and learn about is identifying perinatal mental health disorders, considering the impact of comorbidities, managing psychopharmacology, creating and implementing treatment plans, and adopting trauma-informed practices. The next one is in April.
In Newport News. There is availability. We cap it at 50, so they're smaller. You will have to listen to me talk a number of hours over the course of 2 days. I'm pretty entertaining though when I get going. But if you are interested in this space, if you in particular, I think there are probably a number of pediatricians who find they like early childhood, they like the immediate postpartum period. If that's you, I think you would probably find a lot of interesting information here, and it's a pretty easy way. I was about to poo-poo on Newport News, sorry. Newport News, I'm sure, is a lovely, wonderful spot, but it isn't like, we've branched out and we're having it in the Bahamas, which by comparison, right, might you could see why.
One or another.
But also probably wouldn't be $100 then. So it's a good time. We are really just trying to educate you about perinatal mood and anxiety disorders, expand your baseline knowledge. I am part of the teaching team that does it. So if you're interested, please come.
They do move sites. Right now we're looking at twice a year. We're constantly assessing and evolving. Right now we're at twice a year. So the location of the trainings will move. April, we're in Newport News. Do we know where October is?
We don't know where October is. Probably Northern Virginia. So that might be more of everybody's alley. I don't want to poo-poo in Newport News anymore. Sorry, anybody who's from there, my bad. Also, I do think we'll have an asynchronous learning track. It will, in the coming year, we'll move it to online. We'll be able to provide, much like Pearls and Pitfalls, I don't know if any of you have participated in that, so you can get ongoing CME 1 or 2 credits for doing an hour lecture. That is in the process of rolling out since we're just 2 years old. So look for that. If this feels like too much, that would be a much more targeted, you could see things, and a lot of what we're looking at is stepping outside of the basic perinatal mood and anxiety disorders sort of line up and into things that all of us are maybe seeing more often: eating disorders, ADHD, sleep, time management, things like that, so that you could find something that was of particular interest or you knew was a weak spot for you and just zoom into that.
I probably could have hid this one. I get really uncomfortable with our feedbacks just because, I don't know, I feel like our work speaks for itself, but
in case you worried we didn't get any good feedback, we do.
Right.
A lot of it.
Thank you. Let's go like that. And then just to mention our other line, our pediatric line, of course, and then as Dr. Well mentioned, we do have kind of a sister line, if you will. They're not exactly VMAP, they're a little bit of their own thing, but we do share the same line. And that's our APAL line, or Health Haven Recovery. Right now they're focusing mainly on adults with substance use disorders. However, in 2026, they are expanding into other mental health disorders. So they will, as Dr. Wells said, if you give me a call and you have a patient who has a 15-year-old, I'm not going to take that anymore. I'm going to direct you to APAL this year. Then our citations. All of this, majority of this can be found on our website, which is vmapformoms.org. If you have any questions, multiple ways to get a hold of us. Our medical director, Sandy Chung, our senior director, Allie Singer-Wright, our state program administrator, Hannah Schweitzer, or myself, and then our general Moms Plus email, which also comes to me. So any of those ways, if you have questions, you can also find me in Outlook. That's the beauty of Carilion, right? You can just put my name in Outlook. If you have any questions, feel free to email me. And that's the end of this slide. So I'll leave it there for right now. Any questions?
I'll sort of step into one thing I wanted to say, just as you guys are all Carilion providers and we're Carilion based, I think it's worthwhile in your practices, if you see a mom and you think she is struggling, you have a number of options. You could call the line. We're happy to help you. If you know, if they're receiving care from an OBGYN at Carilion, I don't think it's a bad idea. Right? I don't know what you guys have typically been doing with an EPDS, but if your EPDS is 15 or above, I might shoot a staff message. Hey, saw this patient. I'm not sure if you're aware. EPDS is high. I think there might be a problem with depression. Send that. Hopefully they'll address it or at least respond. I also think you have a role in saying to your patient, hey, who do you regularly follow up with? I'm noticing it seems like it's been a struggle. Do you think you could, use some extra support? And if they have a regular provider, PCP, OBGYN, psychiatrist, say, have you talked to them about your mental health? Or if they're going to an OBGYN, ask them to call the line, just like the case was. It was the patient who had the knowledge, who brought it to the provider to say, hey, you can call this line. I think that's a perfectly reasonable way to approach it, is to inform your patients. It's just something you have to know, patients don't call, providers do, right? It's a clinical consultation line. So in any number of ways, I just want you to be able to access care. If you were really struggling, you didn't know that they had support outside of it, you weren't sure what to do. I am also on my chart. You can find me. People have my charted me. Hey, I'm just not sure. What would you do? I'm happy to help in any way that I can. Does that make sense?
Can you describe how you interact with the providers who are outside of Carilion, like with their primary care, or if they're expecting OB? A lot of this management, do you wind up doing postnatal, or is there a lot of prenatal care interventions that you guys are involved in?
So I love this question because I love data. I'm a data nerd, and that's been my favorite part to watch this past year, is to watch it shift and change. So initially, yes, postpartum. So we're getting a lot of the calls, but we are seeing a shift in that pretty significantly over the last 5 months or so, where we're getting increasingly more calls during pregnancy, which is what we like to see. We've even gotten a few calls with pregnancy.
Preconceptual.
Yeah, preconceptual, which I love even more. We have a patient who's on medication, that psychiatrist or PCP or whoever wants to make sure that these are still safe in pregnancy. But for the most part, in the initial stages, and it's still a little outweighed, it's postpartum that we're seeing a lot of the calls. If we can get them during pregnancy, then we have them established before the delivery, and then they at least have a support net in place. So I want to see that number go up more. As far as outside of Carilion, so they call the line, I answer, I take all the information. We have our own database. We don't use Epic. We have our own database that we use that is HIPAA compliant and everything it needs to be. And then I engage, so if we go to consults, I engage the psychiatrist and they call them directly. I make sure I have a direct contact number for whatever provider is calling in. That way, when the psychiatrist calls, it's a direct doctor-to-doctor conversation. And we usually try to give a time frame best we can. We really try to be flexible with that, knowing that a doctor's day can look different day to day.
Thank you for coming to present. I just wanted to give more of a plug for how powerful I think it is for the pediatricians to be involved in this. From my own experience, and I feel like it can go both ways, negative and positive. I know after my first child, I was filling out the EPDS at one of the early visits and thinking, man, like some of these are a little concerning. And then I got into the office and talked to them, and it didn't even come up. Like, I was like, well, I wonder if he even looked at it. Maybe it's not that bad. And so I walked away feeling like, why did I even bother filling this out? So it does matter when these moms are coming in and taking the time to fill out the form, to at least acknowledge that they filled it out and see if like maybe maybe they didn't score super high, but maybe it was new for them. I think at that time for me it was more of like postpartum blues. But then subsequently, after my second child, I really experienced some severe postpartum depression. And it was my same pediatrician. We had formed that relationship over time. And he just sat me down one day at the well visit and he was like, I am concerned. I really think you need to talk to your doctor. And I scheduled an appointment like the next day with my OBGYN, because you're right, like otherwise I wasn't going back to them anytime soon. And I'm not trying to take care of myself, I'm trying to take care of my child. So I think just so that everybody knows like how powerful it is, like in your position as a pediatrician with those relationships, and that you can make kind of a pretty positive or negative impression on the moms. So
I totally agree, and I see it time and again. I can't tell you the number of providers who have come up to me in the medical field who say, I didn't know I was suffering until I got the little piece of paper and I filled it out. I was like, oh, 22, that doesn't seem that good. And then they'll say like, oh, and no one said anything, so I thought it must be okay. Right? It is a thing. Like, you know, screaming is hard. It's hard to pay attention to it. It's put in front of us every day, but every time, right? Every screen. And now part of why people don't like to screen is because they don't know what to do with the number. Here's what to do. We have a to do. We will be your catch-all. We will try. And it invariably helps either your patient or your patient's parent. And that helps your patient for you guys every time. A healthier parent is going to have a healthier child every time out.
Hi, I'm Dr. Gagan. I'm one of the general pediatricians. The story that stands out to me in the past 20 years was a woman, it was her third baby, and I came into the room for her 2-week checkup, and she was bawling, and she looked at me and she said, I'm so mad you made me fill this out. I was in complete denial about this, and I wasn't going to tell anybody, and you made me admit it to myself. And we got her OB on the phone, and she literally went from my office to their office. I think one of the hardest things here is that sometimes, especially when there's a language difficulty, I'll ask a mom, who took care of you when you were pregnant, and they don't have a name. So if we could find a way, sort of like a pool of just like, if we need an OB contact who can help us, because again, we have to get permission from the mom to go into their chart and trying to sort through, if they saw multiple providers, we still can't necessarily tell who wants to pick up that baton. But I think that would be a great Carilion project to make it easier on pediatricians, because we do sometimes feel like, oh man, if I rip that Band-Aid open, I'm going to need 20 minutes to fix that, before I can legally walk out of the room feeling safe. So finding a way to get moms who are willing to self-identify as needing help to the help that we can't prescribe. But it is, it's the best feeling in the whole wide world. I saw that woman for 10 years after that, and she would just give me a little look and just be like, And then I also have a terrible story that I almost want to tell you, but one of my colleagues had a co-resident, and the wife was just, everything's great, everything's perfect, everything's monogrammed, everything's so great. And one day she gave the baby to her husband and said, I need to go check on something in the backyard. That's it. So when you have a mom that is just seeming a little too perfect, to just have your guard up, to just be like, nobody feels great right now. If you're telling me you feel great, that makes me feel like there's maybe something you don't want to tell me, and that's okay. You don't have to tell me, but I need to know that you'll tell someone. And I often look at the dads and I'm like, hey, we don't have to talk about this in here, but I need to know that you are feeling like this person is your person. They're changed forever by having a baby, but if you have any concerns, you have to tell on them, right? Because I think sometimes dads feel all these social things of just like, my wife's the greatest. And to be able to give dad permission, just like you give the mom permission, to say, it's okay to say that you are awful right now. I'm proud that you are wearing 2 matching shoes. You are fire. Look at you. I think you're wearing a bra. Yeah. But everything else can wait if your mental health is not good. And I think whoever this poor person, and I've had to be a grandpa one time, and he looked at his daughter and he was like, she's not herself. And I was like, all right, then let's get help.
I want to add on to that. It's Moms Plus, right? So we also can connect the non-birthing person or in the household to services as well. So if mom and dad present, mom's already been connected with services. That happens sometimes, but dad is struggling, doesn't know where to go. You can call in place, start a case for dad in that circumstance, or whoever it may be. It may be a grandpa in that circumstance. So we are Moms Plus. We are here for the family within the barriers that we can work out of.
Might be a dad and a dad, might be a mom and a mom, might be, you know?
So that plus is there for a reason. There's no silly call. Worst case scenario, I'm going to tell you, yeah, I don't know that we can help you out with that, but you know what? I'm going to talk to some people and see what we can do. So there's no silly call. I will say I really, the amount of times that I think about how busy you guys are in a day probably takes up a good portion of my day. So I've gotten that intake call down to 7 minutes, and that includes my clinical questioning. It's taken me about 1.5 years to get there, but if you can give me 7 minutes, and if you need less than that, I will do my best to squeeze it into 5. I really will. I get in trouble for it because that means I'm not getting all the information, but I'll take that because you guys are such an important part of this. Pediatricians have a special place in my heart because of this work. There's so many pediatricians that call and mom's not comfortable with her own treatment team, but has such a strong rapport with the pediatrician because they see how you care for their kids. And just like it was mentioned, that's their focus. So to get them to focus on themselves, sometimes it's the pediatrician that's able to make that pivot and that turn for mom. Any other questions or comments or concerns?
Well, thank you.
All. I appreciate you. Thank you for having us. Thank you for being here this early in the morning.
You're good. I don't know how you guys do it.
Thank you for coming.